Hi, my name is Kelly Chavez Rose, and I'm a program officer at the Burroughs Wellcome Fund. Today I'm going to talk to you about a new initiative here at the Fund titled Technology Innovation for Equitable Clinical Outcomes. First, a little background history. The Burroughs Wellcome Fund has ties to the Burroughs Wellcome Company, founded in England in the late 1800s by two Americans, Silas Burroughs and Henry Wellcome. The Burroughs Wellcome Fund was founded in 1955 as the philanthropic arm of the pharmaceutical company. In 1993, the Burroughs Wellcome Fund became established as an independent nonprofit organization. The primary mission of the Burroughs Wellcome Fund is twofold. First, we help scientists early in their careers develop as independent investigators. Second, we aim to advance science that is undervalued, underfunded, or in need of particular encouragement. Our current focus areas include the interfaces of science and regulatory science, of which I am the lead program officer. Dr. McGovern runs our infectious disease, career guidance, and climate change portfolios. Alfred Mays runs our science education and diversity in science portfolio. Raleigh Simpson runs our biomedical science and reproductive science portfolio. And Russ Campbell is in charge of our communications team. When thinking about the future at the Burroughs Wellcome Fund, we run an ongoing assessment of our current programs for both direction and impact, and routinely identify new areas for prioritization. Some examples include our science communication partnerships, such as those with the Civic Science Fellows, National Geographic, and The Conversation. We've also implemented initiative in data visualization as a research tool and communication venue, and have a new RFP in climate change and human health. One new program we are launching is the Technology Innovation for Equitable Clinical Outcomes, or TICO for short. In summary, it has come to light that racial and gender inequities exist in healthcare today in many different facets, including patient care and treatment decisions. In response, some medical schools have developed an anti-racist curricula. One approach BWF is tackling is the idea of inequitable technologies that hinder healthcare, focusing on both physical and computational devices, such as algorithms. One example of an inequitable physical device are pulse oximeters. Pulse oximeters utilize the differences in light absorption associated with oxygenated and deoxygenated hemoglobin. As you can see in this figure, in patients with low melanin content, the spectra have a nice separation, and you can correctly get an assessment of the oxygenated amount of blood. However, in patients with higher levels of melanin, that is to say darker skin, you can see that these spectra overlap, which could lead to false estimates of oxygen levels and delay treatment for these patients. In the computational space, we see two different types of bias. One with an imbalanced data set in which the bias can occur with not an accurate representation of the population. In interpretation bias, one reading from a spirometer can be given a different risk score depending on the race of the individual. This is commonly known as a race correction. This review in the New England Journal of Medicine outlines the various race corrections that exist in several fields of medicine today, and these concerns that exist in using these corrections. In short, these corrections routinely score people of color as having lower risk and may raise the threshold for clinical resources for these patients. In response to the backlash for race corrections, some medical centers have decided to completely remove them from their algorithms. However, as we'll see in the next slide, that might not always be the wisest decision. Research groups have pointed out that a genetic analysis has mostly been done on white populations, and life-saving results can occur when we consider the genetic ancestry. In this study, published in the New England Journal of Medicine, researchers found a large discrepancy in the response to an asthma medication in Puerto Rican versus Mexican American adolescents. When the researchers looked at the genetic admixture, they saw that Mexican American patients had a large amount of Native American and European ancestry, whereas the Puerto Rican population had more of a European and African ancestry. Why is this important? One diagnosis or race correction for someone deemed Hispanic would miss this variation and can lead to treatment decisions that fail in a certain population. In addition, race-based adjustments in neurology, known as Heaton norms, were designed in the early 1990s with good intentions. Dr. Robert Heaton wanted to estimate how socioeconomic factors could affect someone's health. However, the unintended consequences of this research meant that the NFL could incorporate this data into their methodology to make it harder for their former players who were Black to get part of the league's $1 billion settlement. Obviously, this is a complicated situation and with complicated questions. We propose a think tank to convene computer scientists, engineers, physicists, geneticists, physicians, and medical ethicists on tangible, fundable ways to overcome bias in medical devices. We're finalizing our chairs for the committee and plan to convene a think tank in the summer of 2022. We then plan to publish a thought piece or opinion piece and launch a request for proposals in support of this program. I thought it would be interesting for people in this forum to think about the regulatory issues or impediments that could be involved with this type of research. As these ideas move forward, what are possible roadblocks, and how can the regulatory community get involved? If you have data that aligns with this mission or and are interested in becoming a speaker for this forum, please reach out to us. My email address is krose, or KROSE, @bwfund.org. Alternatively, you can check our website at www.bwfund.org for updates. You can follow us on Twitter at @bwfund. Thank you for your attention, and I look forward to the discussion part of the question and answer period, where we can answer any questions and have a thoughtful discussion on this important topic. Thank you so much.